Indonesia itu tolong di rename. Mungkin Alisianya boleh ditelepon WA. Pak dia kan tahu jam tiduran kali. Kamu deh belum join kan? Kasih tahu si itu. Kontak si GB.
Good morning, good afternoon, good evening. Welcome to everyone who is joining us for the Business Unusual, Thinking Differently to Find, Treat, and Prevent TB in Indonesia today. We greatly appreciate your attendance and are looking forward to this wonderful discussion. So next, I'm going to pass it along to some housekeeping and tech updates, helping everyone kind of find their way to the interpretation, and also give us a little bit about how we will do the Q&A. Shane, I turn it over to you.
Hello, good morning, and thank you so much for being here today. So a few reminders that you can use the Q&A on your toolbar to submit questions to our panelists and presenters. Also, if you have any need for technical assistance, please also use the Q&A and I will help you as best I can. Also, we do have interpretation enabled today, so please select the channel that you prefer to hear your language in, either English or Bahasa Indonesian. We hope you can stay for the duration of today's event. However, if not, we are recording today's session. Once again, please submit questions at any time and we'll try to get to as many as possible throughout today's webinar event.
Thank you. And so just a brief overview before we get started here of what we will be covering and how the format will go for today's webinar. We will first have some keynote addresses. Unfortunately, the Minister of Health is not able to join us live. We've had a last-minute change, so we'll be having a recorded video from His Honorable Minister. And then we will have a kind of keynote Q&A, so an opportunity for the audience to ask questions of our keynote speaker, Dr. Lichika Titier. And then we will go into the panel discussion, and then finally the panel Q&A for the audience to ask questions again of our illustrious panelists. So next, I would like to introduce the director of Persahabatan Hospital. Please welcome Professor Agus Dwi Susanto to give us some welcoming remarks and some background for what this webinar will be about.
Gabriela, I think the director has a problem in connecting, so maybe we just continue.
Sure. So now we will go to the Minister of Health, his recorded video for us today. And I will cue that up. Please just give us a minute to cue that up.
Hello.
Greetings to all of us. May all of us be blessed with health and happiness. A couple years back, Indonesia was maintaining its rank as the country with the most population with TB to the second rank, especially during COVID-19. The disruptions that the pandemic created hurt the core of most healthcare systems in most countries, and tuberculosis in Indonesia is one of them. But as Nelson Mandela once said, the greatest glory in living lies not in never falling, but in rising every time we fall. Through tremendous collaborations, scientists, governments, international organizations, and industry have proven that we, working together, we can achieve things we never thought possible. In fact, we have made a new history. Last year, Indonesia achieved the highest number of TB case notifications of all time, which reached 74%, or approximately 717,000 of the overall estimated TB cases in 2022. This was also followed by the TB treatment success rate of 86% of the target of 90%. However, we shall not let down our guard. Despite our great effort, we are still far from our target to end TB. We can do better quickly together. We must invest our time and energy to make another history, creating a world free from TB. By 2030, we aim to reduce the national TB incidence rate from 301 to 65 for every 100,000 people. So, what more can we do to achieve the 2030 target? We need to modernize our understanding of the determinants of TB and ways to approach it. We need to see TB eradications as an investment, not an expense. We also need to scale solutions that work by applying more innovations and engaging more stakeholders outside the traditional healthcare system. Given this, I call for everyone to keep doing their best and to think differently about how to find, treat, and prevent TB in people. Thank you.
Very insightful remarks from the Minister of Health, and we greatly appreciate his participation and comments for to help kick off today's webinar. Now we will go to another keynote address from Dr. Lucica Ditiu. She is the Executive Director of the Stop TB Partnership. She is a Romanian physician, accomplished professional and leader in the global fight against TB and other communicable diseases, and is dedicated to driving political commitment and engagement to accelerate the efforts to end TB. It is such a great honor to have Dr. Ditiu with us today, and I don't really feel like I need to introduce her because she is such a wonderful part of the TB community. So I will hand it over to you.
Thank you so much, Gabriela, and greetings from Geneva. It's a very unfortunate way my camera is set up here with some shades and lights and so on, but this is basically to say that Geneva is saying hello to Jakarta with sun. And it's also a big honor for me, a big pleasure, and I'm really honored to speak here in this important event together with so many amazing leaders and speakers, starting with our partners and colleagues from Indonesia, from the program and from the work. And, you know, I see here our ongoing fighter here under the leadership of the minister, Dr. Budi and Dr. Erlina, and Mr. Budi and everybody, Dr. Henny, as well as my old friend in terms of time, not as age, Dr. Jogan Pillay of South Africa. I don't mention this because I don't have a written speech. I don't have a writer of my speeches as some people have, but I want to give my respect to people that are really in the field and doing the hard work there. Because sometimes in these meetings, we start with this kind of people like me. I'm pushing the global agenda and making a lot of advocacy, but the ones there really fighting the fight and being there with the patients, with the political situation, with convincing the other partners to work are all of you attending here, more than 160 people, plus some of the people that I just mentioned and are today part of the panel. So I took a lot of time to pay respect, to say so, but not without a reason. We heard the Minister of Health of Indonesia about the amazing successes that happened in the country last year, but also the preparation for it started in 2021, or, it's like it didn't come suddenly, right? A lot of work happened previously to arrive at a stage in which in 2022, as we heard, there was a remarkable achievement by Indonesia. And I want to say that the remarkable achievement by Indonesia in diagnosing and treating people is not just an Indonesia success, is a regional success, and is a global success. Because this contributes to probably having in 2022, at global level, the best ever year in terms of people detected with TB and put on treatment, the best number in terms of reducing the number of those that are missed for this. So for this, I want to salute and I want to thank very much the Indonesian program and the work that had happened. The theme of this gathering today is about business unusual. I think the business unusual should be what we should all think about. Nothing should be usual. Usually in TB, people are saying there is not enough ambition. And usually, if you go outside the community, people are like, oh, in general, the TB programs global in different countries, this is not about Indonesia, are not ambitious enough, are not putting the boundaries enough, are not doing that. So the business unusual is to really have the ambition and make the plans and make the national plans and start the implementation of things that are actually leading us towards ending TB. We all embarked into ending TB. And ending TB doesn't mean we will eliminate, doesn't mean we will eradicate. It means we will decrease at global level, at regional as well as at national level, the number of people with TB per 100,000 to a level that is much reduced. I don't want to enter into the technical details, but even in the WHO figures, that global level moved from around 10 to 15 per 100,000 to around 30 to 40 per 100,000 currently, because of changing in the baseline and learning more about how the TB epidemic looked over the years. So I applaud the ambition of Indonesia of dropping to 60 per 100,000 by 2030, which I think is remarkable. So business unusual means have bold targets. And finally, and for those of us that are not just from Indonesia here, there are not many countries in the world that are actually planning this kind of very bold targets. And this is what we need to drive everyone. So business unusual, have very bold targets, ambition to reach indeed the NTB and translate that into a number, translate that into a national strategic plan and in the activities that need to be done. Business unusual means that we need to step up as a TB community, and it's already happening, and use what we learned during COVID. You see, during COVID, there were two things that were learned. First was that you can mobilize resources and political will, you can come together and have a diagnosis, and you can have a treatment, and you can roll it out in a year or a year and a half and so on. And that there is a possibility to have some solidarity, big issues around access to new tools in countries with low income that needs to be addressed, the access and equity, but still it was a global movement in which people stand near each other. So that's one thing that COVID learned us. And we need to use in our business unusual approach. But the other one is the fact that the TB our own doctors, our nurses, our community health workers, the laboratories that were for TB, for in some countries, the databases that were created for TB, the platforms for the phone support, where our hospitals, because of the infection control and so on, became extremely important in the COVID response. If I'm not wrong, Dr. Budi, who was known for the TB leading, he led the COVID response. In my own country, my colleagues that were my peers and TB doctors became the leaders of the COVID response. So it showed that the investments in TB are not helping just TB, are helping others, like other diseases. And it helps that in the future, we need to make sure that the investments in TB will help any airborne pandemic response, but also any airborne pandemic response investments can help TB as well. And the business unusual should be for us to make the links and use the availability of funds currently and the big attention that PPR gets to really invest in things that are for our hospital, laboratories, our staff. That will be, you make good infection control, you procure laboratory equipment that can do multiplexing and other diagnosis, you train the communities and so on. That will help not just PPR, but TB and vice versa. So that's another business unusual. I will not go to all the business unusuals, but I will say just two more. One is embrace new technologies and innovations. And I am extremely pleased because I know it's happening in Indonesia, it's happening in several other countries in the world as well. We need to really take the tools that are available and roll them out. Often for TB is like, oh, it takes so long time in TB to roll out something. It's not the case. There are now a lot of digital tools that are extremely useful, miniaturized. There are tools to do X-ray, mobile X-ray. You take the X-ray, is a bit bigger. It's like an iPad at the machine for X-ray now. And then it works with artificial intelligence. So it's going somewhere, is being read by the cloud. Diagnosis is coming. You can get right away done. You add sputum rapid molecular diagnosis to that, and you can do a very good package that will help not just TB, but other diseases that are located in the respiratory tract. So the other business unusual is embrace innovations and don't be afraid and don't be shy. And the third business is not that unusual, but is unusual because it's happening now in TB a lot, is really get the political leaders and the political commitment to support us. Leaders like Minister Modi, Minister Budi, I wanted to say Prime Minister Modi of India and the President of Indonesia, two leaders of the two countries with the highest burden of TB that committed to TB and pushed the agenda incredible. We know very well that the President of Indonesia launched a TB law even during COVID period, remarkable. So embracing and pressuring as much as we can the people at the leadership level to support us, because in September we have the UN high-level meeting on TB and we need to show this leadership, is the other business unusual. The last ingredient that I didn't mention, but that's because it's not unusual, that should be usual and that should be always there, are the people affected by TB. You see, we all are here. I think, at least I speak for myself, I feel very privileged to be, in this position. And that's why I will always fight for people affected by TB, because they don't have a voice, they don't have an opportunity to really push agendas and to ask what's the best for them. And that's why we want not only to speak for them, we want to bring them to speak, to drive us and to bring all of us to where we are all responsible, deliver the best for them, and to listen and to embrace and to have them not only leading us, but even keeping us accountable. And sometimes doing an audit on all the work that we all do and see if we are really achieving what is needed there. So Gabriela and all the friends and colleagues, as you know me, I get very agitated and passionate when it's about TB, especially now that I really feel that, yes, we can end TB. I'm very honored to speak here. Indonesia is, I feel like, is my second country. I love you all so much. and I respect you for all the hard work that you have done in 2022. And you put the bar high, now you need to go higher. So we do more in 2023 because yes, we can end TB. Thank you.
Thank you very, very much for those inspiring words and those passionate words. I love your passion for TB, and you really, I think, have set the tone for this conversation and have always set the tone for TB efforts to be inspirational and ambitious. And I think you're right that Indonesian colleagues and the work they're doing has been very inspiring and ambitious as well. I do have a couple of questions for you for a quick Q&A. So first off, Dr. Dithiu, what do you think about the challenges and chances for TB elimination after the COVID-19 pandemic? I know that you've kind of spoken to these already. Are there any others that you think maybe the challenges on more of the challenges side that you could speak to, and even on, continuing to expand on the chances that we have now as we're coming kind of out of this pandemic?
Yes, and thank you for that. And just to say that, you see, a lot of people, when we came as Stop TB, we always every year have these long discussions with partners, and then we brainstorm a lot to come with a theme for World TB Day. So the theme this year, and we hope to keep it also next year, is this one: yes, we can end TB. So a few people came to me and said, are you out of your mind? Are you mad? After the COVID, is like, are you drunk? I said, well, no. But I actually think that it's absolutely possible because, as I said, we don't plan to go to zero, right? That's another point that, I very often, I was the other day, somebody from a journalist said, oh, madam, you want to eradicate TB? It's not possible. I say, yes, because we don't plan to eradicate TB. Eradicate TB means no TB. Forget about that, okay? In our lifetimes, all of us here, I see very junior colleagues online here, even in your lifetime, I don't think we will eradicate. By the way, the world, we didn't eradicate anything ever so far. We were very happy with smallpox, but whatever is happening with monkeypox and so on, it's a different story. But we didn't eradicate. So we don't plan to eradicate. We don't even plan to eliminate, which is 1 case per million. Okay, we don't plan to eliminate by 2030. We plan to eliminate by 2050. By the end of 2030, we plan to end TB, and that is feasible because it means, as I said, a dramatic reduction, but not going to zero. And what makes me think it's possible is it's in addition to some of the things that I said there, is I know you will think I'm crazy, and it's true. I cried because in February, somebody told me the numbers that are coming from some of the highest burden countries like India, Indonesia, Nigeria for 2022 are showing that in 2022 we jumped, and we not only went back to what was before COVID, but we did better than that. And big part of that is Indonesia. So thank you, Indonesia, for doing this huge push last year. We will need to continue pushing. But beyond that, it showed that countries really wanted it and pushed like hell. And, with the same stuff that worked for COVID, that it's not necessarily well paid or well regarded, that has a lot of issues. I'm speaking globally, right? The TB workers, doctors, nurses are not the sexiest, right? You know what I mean? Like, we are not I'm a TB doctor. We are not doctors dealing with aesthetics or cardiovascular, these fancy conferences and so on. We are the TB doctors. Very often people are like, you deal with sputum, But this amazing cadre of people, not only doctors, nurses, community health workers, volunteers, managed to do this. So if that was possible in 2022, imagine how much we can do by 2030 by pushing with the new tools coming up, hopefully when we push like crazy with a vaccine, and hopefully with a lot of additional engagement of communities that will push behind, and political leadership. So I think that we will see a revigoration in the TB response. It is possible. And it also showed that during COVID, it was possible to achieve a lot. So we should ask nothing less for our people with TB.
Thank you for that answer. Yes, I think you make some very good points about being able to continue to drive this forward and having realistic goals and understanding those goals. Another question we have for you is, so as you have mentioned, TB doctors have often been at the forefront of the COVID-19 response. And they've been, many of, the TB doctors, you and others working in this field have been fighting TB for many years. You've been involved for decades sometimes. How do these people stay energized? How do they stay motivated? How do they stay committed after all these years, after a pandemic that's taken a lot out of our health workforce? What is your advice to people to keep that passion and that energy that you have?
Thank you so much. You see, this is why I am, and this question, I think, I know that you have discussions. I'm staying obviously online, but what I wanted to say is that that question is a very good question for Erlina. That question is a very good question for Dr. Budi and the other colleagues here that I don't see on the screen all the names. What drives them? But what I can say is that, and this is why I'm so humble, and that's why I said that I think it was 2nd of February, I was actually crying here in the office when I heard, because I knew that nobody else has a merit more than every single one doing his little job at national level, at country level, sorry. And what I think, what drives me, and I think it drives everyone, but I think for sure that the colleagues here will say the same, yoga. I mean, some of us know each other for 20 years, as you said, and we still continue fighting. And there are moments in which we get discouraged. But what drives me, what I can say about me, is the fact that, I come from a very poor background. And I'm the only one in my family that I followed high school and university. And I realized that there are a lot of barriers for certain categories of people to even reach a service, leave aside to receive a quality service. And people with TB are coming in general from vulnerable groups, poverty being one of the groups, but also other vulnerabilities, like many others. And, I feel like I am in this job, we need to speak for them and we need to do the best for them. And it's like, I feel this on my shoulders. We have an opportunity to help them. So we cannot go back, because we are, for some of them, the only hope. And, to ensure that they have treatment, to ensure that they have diagnosis, to ensure that they have access. And I think it's a noble cause, and is noble for us as human beings to be able to help these people that are in a very fragile position and to really make their life a little bit better. We fail in many occasions because there are so many people that die every day with TB. And we used to have a tactic here. Every day we were asking each other, do you think that what we did helped people with TB, few people with TB, to live longer? And it's a tough question to ask. But I think what should motivate us is the fact that, as we have the power, every single one of us here, to help even one single person affected by TB to be better, to be diagnosed, to be treated, to be in a better situation, him or his family. And I think that on one hand should make us embrace, but also me, I feel it as a pressure, because I feel that if I don't deliver, then a lot of things are falling behind, and that keeps me pushing myself and everything, trying to push forward. So thank you.
Thank you for that. We have another question. So how would you advise to attract more business people to join together in the fight against TB? How do we bring in the private sector? How do we bring in the companies that and the workplaces that need to be involved in this fight with the rest of us? Yeah. So thank you very much. So on that one, what I can say, I can say two things. One is there is so people, the first tool to do that is to really let people know. There is very little or little information in the private sector about the burden of TB. The moment we are able to inform them and use statistics and use the numbers, use the evidence, not just the statistics, use the evidence is very important, because that is when they are like, what? Because for the big companies, their workforce is being affected by TB big time. And TB is the Minister of
Minister Budi said that we should look at TB as an investment, not as an expenditure. As a financist, he said that very well. There are new numbers coming from the Copenhagen consensus on the investment case for TB that is not done by us. They are not also paid by us, so they are independent, which shows that investing in TB is a good case. So for the people that are in the business sector, this sounds well. So they need to know the numbers, and they need to know the cost implication of the disease on their business. And that's when they start at least to come together and at least to think about, what can be done. And we have, together with the Global Fund and actually WEF, put together an initiative about ending TB in the workplace, attracting some of the companies to really start doing similarly to what they do for HIV, to do for TB, test the people for TB. And it's not that complicated anymore, or screen at least. So that's rolling, and I think that, so that's one of the tactics. The other is, how do we bring, and we manage to bring a lot of the, in TB, a lot of new developers. There is a mushrooming of smart startups or companies that are developing new tools that are moving very quickly, that are appearing in the TB space. And what they are looking for is some guidance and understanding what's happening in TB, how it is to, get your product approved by WHO or going forward and so on. So it works. It works very well to attract them, because they have some new product or something that is for them very important to have it at least evaluated for quality. So, you can bring them together to discuss and so on, and then they will remain in the TB space once they understand more. And the third thing is, there is one category that when we speak about private sector, I referred here very much to the developers, right, and manufacturers. The private sector providers are a huge importance in TB, and especially in countries like Indonesia, like India, like Philippines, and so on. And for a long time, and I think also in Indonesia, there are some good initiatives. In India, in Pakistan, there are showing that the real partnership with private sector providers works. For a too long time, in many places, I am Romanian, in my own country, actually, people saw the private sector providers as mean for a long time, bad, don't work with them, they will steal our whatever. More and more people understand. I mean, I know that in Asia that's already happening, but I'm saying that even in other parts of the world, that there is absolutely about no stealing. But the private sectors not only need to see what's in it for them to come at the table, but also to see some support in order to be able to be engaged in the TB response. Very often what happens, and it happened in India a few years ago, the private sector providers' data came into the public sector as a, when you diagnose the person, but then it was a hell to get the numbers for the outcome of the treatment, because, the private sector providers are working at a different rhythm, and the reporting of the outcomes of treatment was not something they were looking into it. So that was something that was a bit challenging at the time. So the tactics are, for example, just to let you know, is to engage the private sector providers is all the time we need to think that they will say, what's in it for me? Because basically it's more work. So you see, for example, we managed together last week with USAID and Global Fund to have a negotiations on rapid molecular diagnosis with the Indian company called Molbio. We had an announcement on that. And it was absolutely clear that not it was absolutely clear. It was clear in that announcement, but it's not that what I wanted to say. I'm sorry. We managed to secure a good package for private sector as well, that they are not being charged like up to the moon, but they are charged like the public sector, which was an amazing achievement, because usually it's like, nah, for public sector is this price, for private sector is the other one, and that doesn't help. So that's what I can say. And we in Stop TB are big promoters of engagement with the private sector, because we have a private sector constituency, and recently we created a private sector provider seat in our board. I am a strong believer of engagement with the private sector and a strong believer that we cannot end TB just as a bunch of public health sector people with as much as advocacy as we want. It's a collective effort. So yeah, that's my, thank you.
Thank you. Yes, you're right on the spot with it being a collective effort. And I think many of the people on today and our panelists really will emphasize that as well. So I think we will need to move on. And I'm sorry we weren't able to get to all of the questions for the Q&A, but we will be having a Q&A at the end of the panel. And so if you have a remaining question or have other questions, feel free to continue to ask those. Thank you so much, Dr. Lucica Ditiu. Your comments and your passion, like I mentioned, are very inspiring, and we're truly honored to have you be a part of this conversation with us and have you be a TB leader. So now we are going to move on to our panel discussion. To kick us off, I would like to introduce our illustrious panel. Starting with Dr. Imran Pambudi. Dr. Imran Pambudi is the Director of Prevention and Control of Infectious Diseases at the Ministry of Health of the Republic of Indonesia. He previously served as the head of the Subdirectorate of Tuberculosis at the Ministry of Health from 2018 to 2021. Next, we have Dr. Yogan Pillay. He is the country director of the Clinton Health Access Initiative in South Africa and senior director for universal health coverage. He has been internationally recognized for his leadership in global TB control and elimination. After that, we have Dr. Henny Ahmad. She is currently serving as the national program director at the Panubulu Consortium, STPI, which is the main beneficiary of the TB Global Funding Program in Indonesia. She has over 20 years of experience working with both NGOs and the government on development issues. We have a slight last minute change to our speakers, so Us Kuswanto won't be joining us, but we are being joined by the head of the Jakarta Health Office, Dr. Widya Stuti. And then we also have Dr. Erlina Burhan. She is a highly qualified pulmonologist from Indonesia and is recognized for her contributions to the fight against tuberculosis in Indonesia. She is the head of the Indonesian Coalition of Professional Organizations for Tuberculosis and a board member of the private sector constituency Stop TB Partnership, and the executive director of the Respiratory Tuberculosis Research and Training Center, SATURATE, who is co-hosting this event with us today. And then finally, we have a very special guest, Budi Hermawan, Budi Hermawan, and he is serves as the chairperson of the Indonesian Tuberculosis Patient Organization. He frequently participates as a speaker in seminars on drug-resistant tuberculosis, including the Comprehensive Support Care for People with Drug-Resistant Tuberculosis, organized by USA TB Care in the Philippines, where he shares his valuable insights and experiences as a former drug-resistant TB patient. So we are very honored to have you all with us today and excited to have this panel discussion. And I'll welcome everyone on screen. We'll stop sharing and we'll be able to see everyone's faces. And so I'm going to start the panel with you, Dr. Imran. So the Minister of Health in his video described some of the government of Indonesia's priorities for moving towards TB elimination. So Dr. Pambudi, the toolbox for TB is growing as new screening, diagnostic, and treatment modalities become available. Yet we know that previous innovations struggled to reach scale and be consistently utilized in the short term. What do you think it will take to really accelerate case finding and notification on a practical level? And where do you see the most promise to move the needle? And conversely, which barriers are the most important to tackle? So very easy question, but welcome your thoughts.
Yeah, thank you for your questions. So good afternoon, everybody. Good afternoon from Jakarta, Lucika. Nice to see you here also with all of the colleagues and panelists here. So about your questions about yeah, you asked about that question. So I think we all agree that we need a better tools to accelerate TB program towards eliminations. And we also realize that a lot of new TB tools on diagnosis and treatment is also in the pipeline. And to ensure the rapid adoption of those tools at the country level is quite yeah, complex process, especially if the standard mechanism for rapid introductions of that tools is not available. Evidence generations for strategic decisions on the local research is the second challenge. And also the third challenges will be related on how to financing those new interventions. Because uh, you also knew that nowadays we are struggling also after COVID and then the crisis in Ukraine, and it makes the financial issue, yeah. So it's quite difficult for not only Indonesia but all of the countries in the world. And the other challenge is the intervention will be related on how to ensure the sustainability of program by producing those items in country by local manufacturers. So uh, I think Lutika has also mentioned about the diagnostic tools for the TB. We have not many options, yeah, to this one. First, about the Gen Expert, but recently, Lutika mentioned about the Molbio product. And those uh, tools for the diagnostic is quite expensive one. And also, we should import it there from other countries. So if we learn from the COVID-19, we need to be more resilient for the diagnostic and also for the drugs. So I think in the future, we need to strengthen our local production of the TB diagnostic tools and also what we call drugs, drugs TB. And tackling those four practical challenges will solve many problems. And of course, it needs a high level approach. Since we have also the presidential decree for TB elimination, and I think we can use this TB decree to what we call to gather all of the support, not only from the health sectors, but also from the industrial and also the community and industry to hand in hand to be Indonesia to be more resilient in tackling tuberculosis. That's the answer. Thank you.
Thank you. Yes, I think you make some good points about the need for diagnostics, like Dr. Ditya mentioned as well, and expanding our toolbox. As we know, TB really suffered a setback during the COVID-19 pandemic, and drug-resistant TB clients were among the hardest hit by reduced access to diagnosis and treatment services. So I'm going to turn to Dr. Burhan, Dr. Alina Burhan, and ask about how do you think we need to think differently coming out of the COVID-19 pandemic, and also taking stock of the burden of TB in Indonesia. what are some of the things, what is the business unusual that we need to be using, and how can we approach this differently?
Thank you, Gabriela. And I would like to say hello to everyone, and especially to my dear friend Lucika. Hello. And yes, good afternoon, ladies and gentlemen. I very like this theme of this webinar, Business Unusual, Thinking Differently to Find and Treat and Prevent TB in Indonesia. As our Minister of Health, Pak Budi, has said that TB still is a major public health problem in Indonesia. Of course, I agree, because I'm the player, people in the field. So we are now the second most contributor of global TB cases, with 969,000 new cases per year. And the death cases, 144,000 people in a year. It means 16 TB people die every hour. So Lucika, I'm talking about numbers here. Yes, of course, Indonesia have been making some progress in TB control over the past few years, but there is not enough. We have to do more. So now please say goodbye to business as usual approach. It's time to think differently, out of the box, and invent new approaches. Although medical approaches are crucial, but they make up only a small portion of the overall effort. The majority effort should be among non-medical approaches. Therefore, it is crucial to shift the non-medical approach and non-medical stakeholder. Yes, so there are three critical areas where we can do things differently. The first area is diagnostic. More than 50% TB patients come to the private health facility. And we all say that they have suboptimal quality of care. They have low case notification and also low success rate. We should not blame on them. We should not blame the private health facility for this. Instead, we must help them, such as facilitating them to do good diagnosis procedure. We need to improve availability and quality of diagnostic tool and ensure the patient can access this tool, especially those among the private healthcare facility. Furthermore, we need to expand the use of new diagnosis technology such as Gene Expert, Ultra Expert, XDR Expert, TrueNet, etc. And one other most promising technology is the development of TB biomarker. TB biomarker is very helpful for identifying subclinical TB patients whom we have been neglecting. And also the development of artificial intelligence is also a promising toolbox to help us identify TB and ensure patients receive the specific intervention they need. For my fellow health workers, do not afraid of AI. Artificial intelligence will not replace doctor, but doctors who are using artificial intelligence may replace those who don't. So think and act differently by prioritizing the private healthcare and inclusively involve them on any new diagnostic tool. And second area is the treatment. Currently, we have this standardized treatment, 6 months for sensitive TB and 9 to 11 months or even 18 months for drug-resistant TB. Currently, there is an update that already being launched by WHO that there are a shorter regimen. Even for the drug-sensitive TB, there are 4 months regimen. And even that's just launching the 2 months regimen, that's the trial from truncate TB. And for DRTB, there is a sufficient data show the efficacy, the effectiveness of, and also the safety profile of the shorter regimen, only 6 months. BPAL-M for drug-resistant TB and BPAL for drug resistant pre-XDR and XDR TB patient. So we should do think differently. Do not wait for like currently we always wait for the piloting, operational research. Now we have, I think, with all of the evidence, we do not need to do piloting or operational research. Just do implementation. And the third area is prevention. We must not passively wait for those who are TB infection patients come to the facilities, because they will never come to us because they do not have symptoms. So we have to go to the community, do active case finding. If we do active case finding massively, if Indonesia can do that massively, we will find more active TB cases, more dose infection TB cases, and even we can find subclinical TB, which being neglected. We focus in infection people and active TB, but they're in between subclinical TB. If we do not treat them, sometime in the future they will be developed as an active TB patient. And that's about prevention of and latent TB infection. Now, prevention by doing vaccination. BCG is the only one that's available now. We have to say goodbye to BCG because it was found more than 100 years ago, and most of the babies being vaccinated, more than 90% nationwide, but the incidence of cases is still high. So we really do need a new vaccine. There are a dozen of new vaccine, TB vaccine in a pipeline. So Indonesia have to be very aggressive to be involved right from the beginning, even involving in the trial. Okay, so that is the vaccination, and we can learn from COVID-19 what is the scheme and how to get the high coverage. We can learn from COVID-19. So lastly, as I said before, medical stakeholder only comprise around 40% of the total effort. The majority of the effort, around 60%, are non-medical approach. So please include this non-medical approach and stakeholder in order to combat, reach TB elimination. One more thing, we need to involve also media, especially social media, to increase awareness of TB and its prevention. Luchika mentioned that TB people, they are very, very low profile. Say goodbye to the low profile thing. Please actively in social media, do narcissist thing. Go out there, talk to people. And we learn from COVID. The key of Indonesia is one of the countries that being successful in declining the cases and controlling the diseases. Collaboration of the minister level, collaboration of the leader, cultural leader, religious leader, also collaboration with business people, collaboration in every level. So in conclusion, if we want to reach TB elimination, we need to collaborate, and I would like to loudly asking for everyone, especially those who have not involved themselves on TB program, please participate, take action, and make noises, because TB is everyone's business. Thank you.
Well said. I love that call to action, and to all of us, whether you're involved in TB or you're just a layperson. I think it's really an important thing to keep in mind, that we need to make noise about this. disease, and we need to make noise about the successes and the challenges so that we can really move the needle. Thank you so much for those comments, Dr. Alina. So I think along those lines, I wanted to turn to our South African colleague, Dr. Yogan Pillay. He is joining us to kind of bring in that peer country perspective to share some of the lessons learned that South Africa has taken into account, and where they've had successes and where they've, seen challenges that are comparative to Indonesia as well. So Dr. Pillay, like Indonesia, South Africa has a very complex, faceted TB epidemic. What are some of the key strategies that South Africa has embraced to increase case finding, especially in light of COVID-19? Any lessons on the programmatic scale up on novel screening tools and strategies that you think are relevant for Indonesia? And then also, are there any lessons you think South Africa should take from Indonesia's response?
Okay, Gabriela, thank you very much. And good morning, good evening, good afternoon to everyone. It's a real pleasure for me to be on this panel, and I really can't wait to see my friend Luchika again, which I promised I will, and also my new friends from Indonesia. Just to say a few things. Firstly, I'm very pleased that the minister quoted my former president, Mandela, because I think he has given many countries hope and many people hope. And you may recall that he also suffered from tuberculosis. So, he spoke about TB as a survivor of TB. There are about 8 lessons that we in the TB community in South Africa learned from the COVID response, both our COVID response and globally. And I'll go through them very quickly. The first is that, you have to mobilize people, and it relates to what Dr. Elina said earlier. You've got to work with people, and you've got to work with communities. You've got to have a bottom-up approach, and you've got to socialize TB, because TB is a social disease as much as it's a medical disease. And one of the key lessons we've learned is about trust in government. This is particularly important in South Africa, where more than 90% of treatment occurs in the public sector, which, of course, is provided by the government. So it's very important to have trust in government and strengthen, of course, the people's trust in what government provides or what government says. The second is you must be able to ensure that you use data. And we've used data almost in real time in the COVID response. And unfortunately, we haven't in South Africa been able to do that yet with TB. Yet we've had TB around for hundreds of years. So we need to figure out how to use data, both at local level and at provincial and national level, in real time. So one of the provinces in South Africa is doing, following our experiences in COVID, where we put out daily reports on the number of cases, COVID cases, number of admissions to hospitals, number of deaths, etc., to raise awareness about it. Now, we can do the same with TB. And one of the provinces has a public-facing dashboard on exactly that in South Africa. And I think it's very important for us to do that for TB if we want people to understand the scope and the scale of the problem, and also some of the interventions that they are working with government and other partners on, and its impact. The third, of course, is the use of technology. We had something called COVID Connect during COVID to get people to screen for COVID symptoms and link them to facilities to get tested. We have now adapted that, and we now have TB Check, and we are piloting it currently. And it's basically a free cell phone platform, mobile phone platform, with just the symptom screen on it, and then directing people who screen positive to their nearest facility. We have already screened about 120,000 people in a very short period of time. And with significant cell phone, mobile phone penetration in most countries, this is something we think is possible, especially with younger people. The third is taking drugs to people, taking medicines to people. During COVID, we obviously had lockdowns, significant lockdowns, and patients couldn't receive their drugs. One is we took drugs to patients, and we also had multi-month scripting. So we gave patients multi-month, many months worth of drugs, so they didn't have to come back and forth to facilities. And that's also a lesson from the HIV response. The third, of course, is infection prevention and control, and that also relates to improving in our facilities, in any congregate setting. You know, it's unclear to me why we shouldn't continuously wear masks, especially in congregate settings, for example, provided they are N95 masks and not just surgical masks. And linked to that, of course, is preventive therapy using 3HP, for example. We are scaling up in South Africa, but it's hard, you know, to tell people to take medicines when they are not sick is a hard thing for most people to do. We're finding the same thing with the prophylaxis for HIV prevention, same thing. So we need to learn lessons across the HIV and TB platforms to figure out how we can get people who are otherwise well or asymptomatic or may have subclinical TB to either go for treatment or take prophylaxis. The next is, of course, we moved very quickly out of COVID to provide new diagnostics and new therapies, including a vaccine. And we need to have that same sense of urgency with the TB response. I think it's right, and many speakers before me have spoken about the improving pipeline for TB, but we need to move much faster. You know, in South Africa, we adopted the gene expert molecular testing and scaled it up in a matter of months, only because we had the political support for it, as well as the National Health Laboratory Service, which I'm told the Minister of Indonesia is quite keen to come and visit, and we'd be happy to facilitate the visit should he wish to come and visit our laboratories services here in South Africa. And then finally, the private sector. You know, the private sector, because there was total shutdown, they felt it acutely. They felt the impact of the lockdowns acutely. They did come to the party. Now we've got to learn lessons from COVID, from the private sector's response to COVID. And then finally, you know, we've learned also about multimorbidity, that patients are now presenting with more than one condition. And we have to therefore retool our health systems to ensure that we are picking up the other conditions that patients do not present with, but have, but often don't recognize, so that we treat patients. I know it's kind of a rhetorical thing to say that we treat patients in a patient-centered way, but it's fairly clear that with multimorbidity, with patients presenting with multiple conditions now, we need to really focus on changing the way we deliver health services, including taking services to patients. And then my final point is about reducing the prices of diagnostics, as well as the therapies, including things like, I know Dr. Elena has spoken about BPAL. We have to reduce further the prices of bedaquiline, for example. It's still very high. We are currently working with the Johnson & Johnson to figure out how to reduce the prices even further. We have to reduce the prices of some of these. So I think, you know, there's 8 lessons that we've learned. We are applying it to finding the cases. We've got about 150,000 people with TB who are missing from our notification systems annually. So we've got to get them into our system and get them treated and get them cured. Thank you very much.
Thank you. I think your comments about harnessing the kind of mobilization that we saw with COVID-19, so harnessing that for TB is really, you know, relevant and hopefully something that we can take from the pandemic, as well as your kind of notes about how do we get the community involved and how do we, you know, encourage people to take preventative medicines and things like that. I think that kind of leads into my next question for Dr. Hani Ahmad. So Dr. Hani Ahmad, when we talk about identifying missing cases and adherence to treatment, we can't help but also discuss this community engagement piece. I think we can agree that pushing services out to communities where clients are requires a well-equipped and capacitated community workforce. So how can we better support caterers to meet this need? Are there existing lessons that we should be taking to scale or new strategies we should try? We would love your thoughts on that.
Baik, terima kasih. Saya akan berbicara dalam bahasa Indonesia, so I would like to speak in bahasa. Di dalam forum yang sangat penting siang ini, saya ingin menyampaikan bahwa bekerja dengan kader itu memang hal yang luar biasa menarik karena mereka juga ujung tombak kami di lapangan. Dan kalau dilihat sampai hari ini ada sekitar kami bekerja sama dengan sekitar 14.000 lebih kader, tetapi yang aktif sekitar 9.300 yang tentu saja semuanya telah terdaftar, dilatih, diperkuat dengan alat-alat kerja dan pengetahuan yang cukup untuk bekerja di lapangan. Dan mereka di lapangan akan melakukan kegiatan edukasi melalui community outreach, menemukan kasus secara aktif, mendampingi pasien dan keluarganya seperti yang disebutkan tadi. Dan bekerja dengan kader ini dengan berbagai latar belakang dan dengan konsep yang selama ini diterapkan, konsep result based, itu penuh dengan hal-hal yang baik, tapi juga banyak tantangan-tantangannya di lapangan. Dan hal yang positif bekerja sama dengan kader ini adalah kalau keinginannya, harapannya ya, tidak hanya kader tapi sebetulnya seluruh masyarakat bisa bergerak bersama-sama terlibat di dalam program tuberkulosis. Artinya apa? Artinya anggota komunitas yang bekerja sebagai volunteer ini masih sangat dibutuhkan. Mereka melakukan edukasi langsung ke masyarakat dan idealnya ke depan memang menjadi satu gerakan ya, movement gitu, di movement menjalankan eliminasi tuberkulosis di Indonesia, jadi di seluruh negeri, dan ini juga inline dengan gagasan people atau patient center di dalam layanan tuberkulosis. Kami juga berpikir bahwa perlu juga dilakukan pendekatan keluarga ya, jadi mendorongkan pendekatan keluarga agar bisa menjadi satu gerakan yang utuh selain adanya kader. Dan movement ini atau gerakan ini memang dimulai dari masyarakat, kemudian naik level yang lebih tinggi ke sampai pemerintah nasional dan lebih luas lagi. Dan berkaitan dengan pertanyaan apakah ada strategi atau pengalaman yang bisa ditingkatkan lagi, kami sekarang ini sedang bersama-sama dengan CSO yang lain mengembangkan konsep community health worker yang sebetulnya itu panduan atau guideline-nya ada dari WHO dan Global Fund yang menyebutkan di salah satu dokumennya tentang satu global trend ya, penempatan community health worker ini berbasis kompetensi dengan sifatnya yang lebih profesional, artinya ada target yang harus dicapai, terukur dengan baik, didukung sistem pencatatan dan pelaporan yang baik dan akurat, juga direkrut secara profesional. Mereka ini nantinya sebagai community health worker akan punya tugas yang jelas dan dibekali juga dengan pengetahuan yang cukup, dan tugas dan tanggung jawabnya sebetulnya dia akan lebih luas dengan kader yang result based yang ada sekarang ini. Tetapi sebetulnya dua-duanya sama-sama sangat penting ada, jadi saling mengisi dan ke depan mungkin juga sebelum pelaksanaannya tentu diperlukan assessment lebih dulu, kemudian melakukan piloting sebelum diimplementasikan untuk wilayah yang lebih luas lagi. Dan saya juga setuju tadi ada sudah disebutkan sebelumnya penggunaan teknologi seperti chest X-ray, AI, itu juga bisa sebetulnya melibatkan, sekarang ini juga sudah dilakukan pilotnya, melibatkan kader, terutama untuk mobilisasi masyarakatnya. Kemudian juga bekerja sama dengan layanan kesehatan primer, dinas kesehatan di daerah, ini menurut pengalaman kami ya, dan juga dengan seluruh stakeholder yang berkaitan dengan layanan tuberkulosis, sangat penting sekali. Kalau yang lalu-lalu model kerjasamanya, koordinasinya itu biasanya mungkin misalnya hanya di satu tempat di kantor, tetapi sekarang sudah bersama-sama bergerak ke lapangan, bersama-sama aktif bekerja di lapangan untuk bertemu dengan masyarakat, dengan keluarga-keluarga pasien, sehingga dari sisi data pun juga lebih akurat, dan kalau ada masalah di lapangan bekerja sama dengan kader dan dinas kesehatan dan praktisi kesehatan lainnya di lapangan secara langsung itu sangat membantu dan memperlancar memperlancar kerja-kerja kami di lapangan. Dan memang ini juga menjadi kunci yang sangat penting ya untuk menjalankan konsep community health worker nantinya. Satu hal lagi mungkin yang saya juga ingin tekankan, jadi memang kalau sebagai ujung tombak kita menyebutnya kader ya, atau community health volunteer. Sebagai ujung tombak memang perlu ada beberapa hal yang masih perlu ditingkatkan, dan harapannya dengan konsep yang community health worker ini nanti keduanya bisa saling melengkapi dan mendukung proses eliminasi yang sudah kita canangkan di 2030. Semoga dan harus tercapai.
Excellent. Thank you so much for those comments, Dr. Ahmed. I think your notes about, expanding the technology, that's definitely a thread that I'm hearing throughout these comments from all of our panelists, and your comments on kind of using that technology to mobilize the communities is a really important point. And I think it leads to our next speaker. And actually, we've had a slight change in speakers. So I'd like to introduce Dr. Dwi Octavia. She is the head of disease prevention and control at the Jakarta District Health Office. And so I think getting the perspective of the District Health Office after your comments, Dr. Ahmed, are really relevant to kind of continuing this conversation. So Dr. Octavia, the impact of TB is felt differently by communities in different parts of Indonesia. And in a practical sense, many day-to-day decisions about how to respond to fall to municipal leaders. What are your priorities for accelerating the TB response in Jakarta specifically? What are the key ways in which national policymakers, international donors, or partners can better support leaders like you to tackle TB more effectively?
Baik, terima kasih. Selamat sore waktu Jakarta atas kesempatan yang diberikan kepada kami dari Jakarta, Dinas Kesehatan Provinsi DKI Jakarta. Mohon maaf saya mewakili Ibu Kepala Dinas karena beliau saat ini persis bersamaan dengan kegiatan lain ya, jadi tidak bisa bergabung. Saya adalah Kepala Bidang dari Pencegahan dan Pengendalian Penyakit di Dinas Kesehatan DKI Jakarta. Jadi untuk situasi tuberkulosis DKI Jakarta, kami memang mempunyai cukup banyak tantangan, namun juga peluang dan kesempatan yang luar biasa. Sejauh ini upaya bersama-sama untuk menanggulangi TBC di DKI Jakarta dilakukan bersama. Jadi tidak satu sektor pun yang bisa melakukan penanggulangan TB ini secara sendiri. Demikian juga di Jakarta. Dari pemerintah daerah, maka kami menyiapkan perangkat tentu saja yang mulai dari tingkat provinsi, di tingkat kota, di 5 kota dan Kabupaten Kepulauan Seribu DKI Jakarta, dan juga di tingkat kecamatan atau subdistrik di 44 kecamatan yang ada di Jakarta, di mana semua layanan kesehatan yang dimiliki pemerintah, baik merupakan primary healthcare maupun juga rumah sakit milik pemerintah, juga sektor swasta dan rumah sakit yang ada atau klinik swasta juga ikut berkontribusi dalam melakukan pelayanan tuberkulosis, mulai dari penemuan kasus sampai juga dengan tata laksana. Kemudian juga tentu dukungan dari CSO yang selama ini sudah all out juga bersama-sama dalam bentuk penjangkauan, kemudian pendampingan pasien, dan memberikan support juga dalam bentuk fasilitasi untuk mendukung layanan, itu merupakan kekuatan kita juga. dan juga bagaimana layanan penanggulangan tuberkulosis tidak hanya pada pasien tuberkulosis sensitif obat, tetapi juga pada pasien tuberkulosis resisten obat yang saat ini di DKI Jakarta jumlahnya ada sekitar 714 pasien yang kemudian penanganannya tidak hanya bisa dilakukan di rumah sakit, tapi juga bisa dilakukan di tingkat primary healthcare. Jadi ini merupakan kekuatan juga tentunya supaya pelayanan tuberkulosis bisa dilakukan di lebih banyak tempat, baik fasilitas kesehatan milik pemerintah tetapi juga milik swasta, dan juga pelayanan itu didukung oleh CSO yang memberikan pendampingan, penjangkauan, dan kemudian juga memberikan support lain kepada pasien tuberkulosis juga kepada keluarganya. Jadi tentu kita masih perlu terus bersama-sama ya, karena penanggulangan TBC ini di Jakarta masih mempunyai tantangan. Saat ini kita rata-rata menemukan kasus sekitar 42.000, 43.000 per tahun kasus baru, dan kita tentu masih harus menemukan lebih banyak lagi karena mungkin masih banyak kasus-kasus yang masih terjadi penularan di masyarakat dan tentu masih perlu ditemukan lebih cepat dan diobati. Terima kasih.
Thank you very much, Dr. Octavia. I think your notes about working together and reaching in the communities and working with patients and their families is really relevant, and also kind of leads into our next speaker, Pak Budi Hermawan. So Pak Hermawan, I think we can admit that for too long, TB clients themselves have not been kind of leading the development of solutions to improve TB services. Have you seen this changing at all post-COVID? What priority measures can be adopted to give TB clients a greater voice?
Ya, terima kasih. Selamat sore semua. Senang sekali dapat hadir pada sore hari ini. Jadi kalau untuk menjawab itu, yang pertama kita di Indonesia semasa COVID memang kita banyak sekali tantangan yang dihadapi oleh komunitas dalam beraktivitas, terutama dalam penanggulangan tuberkulosis. Tapi setelah ini kita sudah perlahan-lahan maju lagi, kita sudah menggeliat dan lebih maju, terutama untuk komunitas sendiri kita sudah banyak terlibat di Indonesia dalam memberikan suara-suara gitu ya. Salah satunya kita kembangkanlah adanya mekanisme umpan balik atau community based feedback dari pasien TB. Indonesia bersama pihak konsorsium Penabul STPI mengembangkan aplikasi yang memang bisa berdampak gitu ya, cukup baik, itu di mana kita bisa memberikan feedback kepada pemerintah maupun pengelola program TB agar layanan bisa jauh lebih baik lagi dan sesuai dengan kebutuhan pasien. Di Indonesia sudah sangat dilibatkan gitu dalam hal-hal penting, baik dari beberapa kolega kami gitu, rekan-rekan kami itu yang masuk ke dalam anggota CCM maupun TWG, Technical Working Group, yang tentunya ini betul-betul bisa dijadikan perwakilan kami untuk menyuarakan suara-suara terkait dengan kebutuhan pasien. Begitu juga untuk teman-teman kami juga, para penyintas, sekarang ini ada 22 organisasi di 17 provinsi di Indonesia yang mereka semua bekerja membantu pemerintah dan juga PR komunitas tentunya dalam pendampingan, lalu juga kita sudah membentuk tim paralegal gitu, bagaimana kita memberikan terkait dengan literasi hukum bagi pasien-pasien tuberkulosis yang sedang berobat dan juga dampingan hukum jika memang dibutuhkan. Dan tentu ini kita kembangkan agar pasien itu merasa lebih nyaman dan betul-betul dirinya itu didukung oleh komunitas dan pemerintah.
Thank you, Pak Kermwam. So I think in recognition of the timing, we're going to jump to the Q&A here with the audience so that we can at least answer a few of the questions that have been coming in. And I think the first question I would like to direct to Dr. Imran Pambudi. So use of data in TB is low, especially in Indonesia. There are digital interventions in place in Indonesia. Those are not optimally used according to the Indonesia Digital TB Surveillance System Assessment Report. So what are the challenges in the adoption of the digital tools? What are the government of Indonesia efforts in pushing this forward?
Yeah, I think the most challenges of digital is from the health providers. Yeah, because if you want to make a shift from the manual to digital, it should be we need to make sure, yeah, that this product is better than the manual one, the old one. So I think this is the most important. And the second thing is that we have to know that Indonesia is very fast country. We have more than 17,000 islands, and not all of the health centers is connected with internet, and also the electricity in some area is also not sufficient yet, electricity. So this is I think this is the two main. However, we already improved for how the TB reporting and recording system to be digitalized. So we already improve our information TB system to be more agile, to be more what you call lighter. So it means that these apps will be light. It means that they need no more what you call the big bandwidth for this one. So this is I think it will be more easy to health provider, especially in the remote area, to access this one. And also for the area that has no internet and also limited electricity, we also still give them the options of the hybrid. Yeah, so it's not a real time, not a real time information system. So they will connect it when they got the internet. So it will be useful for them to use this kind of hybrid system. And other things that I think, thanks to Minister Budi, that they always push us to use the digital things, because I think when all of the system are digitalized, we can work more efficiently, more effectively. So under his what we call leadership in Ministry of Health, we have a digital transformation office. So in this office, in DTO office, the purpose of this office is to connect or to build the what we call the one platform of digital in all of the program in Ministry of Health. So it means that all are connected, and it will be more efficient to have in the one platform. So I hope this answer will answer your questions. Thank you.
Thank you, Dr. Pambudi. Definitely streamlining and finding those chances to be able to make it less of a hybrid situation is will help kind of streamline, like you say, and make it more feasible to do real-time data entry and collection. My next question is for Dr. Pillay. So in your experience, Dr. Pillay, as a country director for South Africa, what are the challenges in engaging the private sector and how do you respond to those challenges?
Great question. Thanks very much. So, we've got this experience from COVID, as I said earlier, which we must maximize. And I think the one thing that's true about the private sector is that it's not homogeneous. It's not one thing. The private sector is many things. There are many different sectors that operate in the private space. And we need to be, quite clear about who we want to reach and why. So in the South African context, for example, we've got a significant number of mines, mining everything from gold, which has major implications for silica dust, etc. But we also have coal mines, platinum mines, etc. So, we've engaged quite successfully with the mining companies to ensure that they screen the miners regularly. And now it's become part of health and welfare and health and safety on the mines, which is regulated by government. So there's an obligation on the mining owners, the mine companies, to screen miners regularly for TB. We've also managed to engage them to focus on what we've called the peri-mining communities, meaning the communities around mining areas, around the mines. Because our argument is that many of the miners live in these communities, and therefore they need to adopt these communities as well. So there's been some success in mine owners, mining companies, adopting communities around the mine. We need to also, of course, work with the pharmaceutical companies and the companies that make diagnostics to ensure that they decrease prices. And we can do that by joining forces and using global benchmark prices to force down prices. Now, we've not succeeded in doing that with GeneXpert because there's no real competition. And we stuck with GeneXpert from Cepheid because of lack of competition. So, for diagnostics, therapeutics, and hopefully soon vaccines, we will need competition. And one way to get that is to move to generics where possible quite quickly. We also need to, of course, work with people who work in shops and cafes and restaurants, because it's in their interest to ensure that their employees are free of TB or any other infectious disease. So there are opportunities there because obviously they wouldn't want their employees to transmit TB to their customers. That would be a very bad advert if word got around that they were not taking care of their employees and therefore infecting their customers. So we need to be creative in segmenting the private sector and really focusing on the private sector in a very differential in order to get the private sector to understand, or the different sectors within the private sector to understand why it's in their interest to take care of their workers as well as the workers' families. Thanks, I'll stop there for now.
Thank you for those comments, and interesting to hear about the mining side of it in particular. Are there any other panelists who'd like to add to that and add to strategies for engaging private sector? Any other thoughts?
Yeah, can I jump into this discussion?
Please,
yeah. Right. Yeah, so I think some points that our colleague from South Africa has mentioned also. I think what I learned to bring private sector in the program is they have to also know what is the benefit if they are together with this what we call collaboration, because I think the mutual benefit should be also be considered. We are not only give them a task, but also they have already also know that what is the benefit for them. Like example, in Indonesia now we have MOU with the 5 big chain hospitals. That we want to engage them to TB program. And in the discussion, we also say that what is the benefit if they bring to they collaborate with us. For example, like they can have an access for the gene expert machine, for example, to diagnose TB. And also we have what we call the e-learning for TB. It's also free for them who can engage. And we also have the MOU with the what we call Indonesia Doctor Association to give the doctors a credit who they so we will give them additional credit for the doctors who treat and find and also report TB patient in our system. So those kind of what we call non-financial incentive, yeah, will be bring them insight. What is the benefit if they can collaborate with government? Thank you.
Thank you. And I think those are going to be our final words as we wrap up here. I could talk about this for many more hours, but I know that all of us across the world have new and different parts of our days to get to. So I appreciate everyone's time. And on behalf of RTI International, my co-host, SATURATE, thank you to the keynote speakers and the panelists, and to all of you for participating in our webinar today. Thank you as well to the translators and to our admin and tech teams. The recording will be available to all of you who are registered, and we'll be sharing that via email. And as World TB Day is approaching, I hope all of you will be inspired to think differently about TB and look for ways you can contribute to fight the end to TB.
Thank you, everyone.
Thank you all.
Okay, thank you.
Thanks very
Bye.
much. Bye-bye.
Yeah. Bye.
Good day.
Ruchika, see you in the Delhi, Ruchika.
See you. I'm sending you a love letter now. You'll see with few ideas. Thank you. Hi,
Thank
bye.
you, thank
See
you.
you all.
Yeah,
We'll
bye.
meet in Varanasi.
Yes.
Yeah.
Varanasi.